Greetings, everyone. My name is Dr. Joyce Wamboi, and I'm a consultant physician and a budding endocrinologist. Today, I want to introduce you to my YouTube channel. You're welcome. And I want to discuss a topic that is important in endocrinology, and this topic is called non-diabetic hypoglycemia. So what is non-diabetic hypoglycemia? Non-diabetic hypoglycemia will be defined starting from the definition of hypoglycemia itself. Hypoglycemia is simply low blood sugar, and low blood sugar occurs when your sugar levels are below 3.3 millimoles. And when you have such low blood sugar levels, usually people expect that you're diabetic and you are using diabetic medication, and thus an overuse of this diabetic medication would lead to you having low blood sugar. However, there are patients who develop low blood sugar and yet they are not diabetics. So that simply defines what non-diabetic hypoglycemia is. Simply having low blood sugar and yet you're not diabetic. So what are some of the causes that would lead to you having non-diabetic hypoglycemia? One, we have causes such as what we call factitious hypoglycemia. Two, we have reactive hypoglycemia. Three, we could have medication, including things like excessive alcohol use that would lead to hypoglycemia, patients who've undergone bariatric surgery, or even patients who have a tumor. Usually a small tumor in your pancreas that is producing insulin, and that is what we call an insulinoma and will be the focus of this discussion. So simply going through the causes in a short way so that you can understand what non-diabetic hypoglycemia is, I'd like to simply define them. So factitious hypoglycemia is when somebody is using medication for diabetics, so to speak, diabetic medication that would lower your blood sugar, and yet they're not diabetics themselves. This condition usually has a mental element to it, mental health element to it, whereby patients would want to use medication to get the symptoms of hypoglycemia for one reason or another. That's a long topic by itself and it's not the focus today. Number two, we could also have reactive hypoglycemia. Reactive hypoglycemia is basically having a robust response of your insulin, which is usually produced after a meal, such that it's so high, your insulin production is high and causes a dip in your blood sugar, to the extent that you have hypoglycemic symptoms. This occurs postprandially. After a meal, you have a robust response to insulin produced in your body, and you end up having the symptoms of hypoglycemia. Bariatric surgery as well can cause hypoglycemia and tumors, which I will explain shortly. So let's discuss insulinomas. What is an insulinoma? An insulinoma is a small pancreatic tumor, usually that arises from, we call it a neuroendocrine neoplasm or tumor that arises from the cells of your pancreas. As we know, the pancreas produces insulin from the islet cells of Langerhans, and these cells produce insulin in response to the food that we eat. So usually, if you have an insulinoma, if a patient has an insulinoma, they have a small collection of cells that are tumorigenic, meaning they are cells that have grown erroneously in the pancreas, and this leads to production of insulin. They come from the very cells that produce insulin. When you have an excessive production of insulin from these cells, then you develop symptoms of hypoglycemia, since you're producing insulin despite having despite response to a meal. So it doesn't matter at whatever point you are producing insulin, sort of like throughout. So this means that you're going to develop these symptoms of hypoglycemia. They are rare tumors and mostly they are benign, meaning they are not cancerous or malignant. Having a rare tumor, in terms of the epidemiology, about 1 to 3 people in a million people would have an insulinoma. That means it's pretty rare. So why is this important? It's important because if a patient presents to you with symptoms of hypoglycemia, it's one of the things that we need to rule out in such a patient. And I will take you through the steps in diagnosing an insulinoma, in managing an insulinoma. So let's start with the symptoms. For you to define an insulinoma, or for you to define hypoglycemia, we use what we call the Whipple's triad. The Whipple's triad is simply a constellation of three symptoms, or three components that would have: one, symptoms of hypoglycemia; two, a documented levels of hypoglycemia, as I said, documented levels below 3.3, or number three, you have a correction of the symptoms of hypoglycemia once the low blood sugar is corrected. In other words, you respond to measures such as giving you a sugary drink, you respond to measures such as giving you glucose. So that's called the Whipple's triad. Simply put, when you fulfill the Whipple's triad, then you have hypoglycemia. Okay, so once you have established that a patient has fulfilled the Whipple's triad, then you want to ask yourself why. Usually in a patient who has an insulinoma, they will have fulfillment of the Whipple's triad, and a second symptom they might present with is actually weight gain. Why do they get weight gain? Because they tend to eat a lot. The fact that their sugar goes low makes them hungry and they want to eat a lot. So over time, they do develop weight gain. Fine. So after you have established that the components of the Whipple's triad are met, and this patient probably has weight gain and you're not understanding why, then you want to go further and do certain tests. But before we go there, I want to describe these symptoms of hypoglycemia. Symptoms of hypoglycemia are simply divided into two main components. There are those that are called neuroglycopenic symptoms, and there are others that are adrenergic. When you have neuroglycopenic symptoms, simply put, that means the low blood sugar affects your function, the brain function. And when your brain is affected, then you present with certain symptoms. For example, you tend to be confused, agitated, you could have altered behavior. You're not yourself, really. You are having symptoms like blurring of vision. You're having symptoms like starting to have seizures. When the sugar gets a bit lower to the ranges of around less than 2, you can have seizures, which are basically convulsions, or you can even be in a coma, and it can actually lead to death. And that is why hypoglycemia is important. You could also have adrenergic symptoms. What are these? These are symptoms that occur after your body is going through a bit of a stress. And in this case, the stress is low blood sugar. So what are some of the symptoms that are adrenergic symptoms? One, you could have your heart rate starting to go a bit up. So you have what we call a tachycardia, or you'll have palpitations. You'll feel like your heart is beating and your heart is racing quite fast. So you have tachycardias or palpitations. You could start having tremors or sweating. And that's important. So that's another symptom. You're having excessive sweating, you're shaking, you're anxious. So together, these are the symptoms that hypoglycemia would cause, or low blood sugar would cause. So again, Whipple's triad, you have symptoms of hypoglycemia, you have a documented level of low blood sugar, less than 3.3, and you have correction of these symptoms when your sugar is administered, either in form of a drip or in form of even oral sugar. So that's Whipple's triad, and those are the symptoms. So let's go to the next part of diagnosing this patient. So biochemically, what we tend to do is we move on to subjecting a patient, and this is what they call the gold standard test. This is a biochemical test whereby a patient is admitted for our 72 or sometimes a 48-hour fast period. So a patient will come and we'll take them to the ward or under supervision, whereby we subject them to a fast. So I don't want to get to the details of it because it's a bit technical, but during this period of the fast, we are trying to determine whether, one, you have low blood sugar and you have high insulin production, because as I described earlier, an insulinoma would mean that you are producing insulin throughout, or you're producing insulin not in response to food or to a glucose load. Meaning that when we subject patients to this supervised test, we want to measure the levels of their glucose. 2, we measure the levels of your insulin. So when your insulin, most likely it's going to be high. So your insulin is going to be high. 3, we measure what we call proinsulin and C-peptide. These basically are components of your insulin molecule before it's broken down. So that will also be elevated. You'll have high C-peptide levels, you'll have high pro-insulin levels. But for this test to be accurate, we also need to rule out if a patient has been using what we call sulfonylureas. These are basically drugs that will induce reduction in your glucose levels. However, they are causing an increase in your insulin levels in the body. So we need to rule that out. As I said, it's a bit technical, so we will not go into too many details where that is concerned. But in a nutshell, you're subjected to a fast, and we'll measure the C-peptide levels, the pro-insulin levels, the insulin levels. All those three components should be high against a low glucose level. I hope that's clear. So let's move from the biochemical diagnosis, which basically are the things I've explained to you. After we have established that you have a biochemical diagnosis for an insulinoma, then we move further to the next component of the diagnosis. And this is basically to localize. We are now sure, more or less, that you probably have an insulinoma. How do we then localize it? Know where it is. This is where we do imaging. And basically, imaging means radiology. We need to do a scan. And what we use is a CT scan of the abdomen, or an MRI of the abdomen, or what we call an endoscopic ultrasound. So for the CT scan, it's pretty good. Actually, it will be able to pick up the lesion in the pancreas, and usually it's anywhere in the pancreas. An insulinoma does not particularly have a predilection to any part of the pancreas, so it can be anywhere, either in the head, the body, or the tail of the pancreas. So a CT scan is important, abdominal CT scan. MRI can also help us to find the smaller lesions that could be in other parts, which we call metastasis. Remember, we said that an insulinoma is mainly benign, 90%, but there's that small percentage that could actually move to other parts of the body, like the liver and even the lung and other parts of the liver, of the body. So an MRI would be useful, or an endoscopic ultrasound. Where that comes in handy is that it can also take a biopsy. Part of that tumor can be taken to the lab using endoscopic ultrasound. So finally, I want us to go into treatment. So why did we need to localize this tumor? The reason we localize the tumor is so that it can guide in treatment. The mainstay of treatment for treating an insulinoma is usually surgery. And in surgery, we have various different types of surgeries, which of course we'll not go into right now, but that's important for you to know that this tumor is surgically resectable, because one, they're usually small, and two, they rarely metastasize. So the mainstay of treatment is surgical resection. When you remove that tumor from your body, what happens? You have a very good chance of survival. And that's why it's important to make a good diagnosis, and once we diagnose, we localize the tumor. And once we localize, then we go ahead and treat the tumor surgically. Meaning that once you go through surgery, what are the chances of you surviving? The chances are pretty good. The chances are about more than 90% in 5 years that you'll be okay. You'll basically have chances like any other person to survive despite having this insulinoma. So what happens after that is simply we talk about follow-up. You'd want to follow you up and see if there's a recurrence of the tumor, or if you have signs and symptoms of hypoglycemia, and probably in that regard, then we'd want to reassess you, do another CT scan or MRI, and check and subject you to another fast if you have symptoms of hypoglycemia. That's it. That is all for today. That's basically what an insulinoma is, and I wanted to bring this to your attention because it's important for people to understand that there are other causes of hypoglycemia that could occur in a patient, and when this patient is not diabetic. So thank you so much for tagging along for this short clip. I hope it has been of value to you and educational. And yeah, so like, subscribe, and comment, and I will be there to answer your questions. Thank you.